again. We will take a couple of minutes to allow everyone to join us. Thank you for your patience. We will begin shortly. Right. Good morning, good afternoon, and good evening, everyone, wherever you are joining us from. Thank you for being part of this important episode of Infinite webinar series. Today's session is the fifth in the One Health webinar series, brought to you by Infinite in collaboration with RTI, and is titled Environmental Surveillance, Enhancing Public Health Resilience in the EMR and Beyond through One Health. I'm Syed Himmat, a public health specialist based at Infinite's headquarters in Amman, Jordan, and I'm honored to serve as your moderator for this important discussion. A warm welcome to our distinguished panelists, policymakers, public health professionals, academics, and One Health stakeholders joining us today. It's wonderful to have such a diverse group of participants with us from all around the world. Environmental surveillance has emerged as a transformative tool for public health, offering a non-invasive, cost-effective method for early detection of communicable diseases and antimicrobial resistance. By systematically sampling water, air, soil, and waste, this approach provides critical insights into population-level health trends and offers an early warning system for emerging threats. In regions like our region, the Eastern Mediterranean, environmental surveillance is especially vital. Challenges such as water scarcity, urbanization, and climate change amplify health risks, making it important to integrate this method into the One Health framework. Over the next 90 minutes, we will hear from 3 esteemed experts who will share their experience and insights on environmental surveillance. We will also have an interactive Q&A session toward the end, where we look forward to your contributions. Before we begin, here are a few housekeeping notes. Please use the Q&A tab to submit your questions at any point during the session. If possible, please direct your questions to a specific speaker. Please feel free to use the chat tab for general comments and introductions, but remember to reserve questions to Q&A tab so they can be visible to me. Thank you again for joining us today, and let's get started. Our first speaker is Professor Mahmoud Rahman, a highly esteemed public health leader and epidemiologist with over 37 years of experience in communicable disease control and surveillance. He currently serves as the country director of Infinite office in Bangladesh and is a member of several high-profile national, regional, and international advisory committees. Previously, Professor Rahman served as the director of Institute of Epidemiology, Disease Control and Research in Bangladesh, where he led groundbreaking initiatives, including the establishment of surveillance systems, foundation of field epidemiology training programs, and advancing the One Health approach in the country. He also authored almost 180 research publications and studies. Today, Professor Rahman will share insights from his work on water and soil sampling to detect myeliodosis in Bangladesh. Professor Rahman, thank you for joining us today. The floor is yours, sir. Please.
Thank you, Dr. Saeed. Good afternoon, good morning, and good evening. Where are you joining from? I will be start doing my presentation. Let me upload my slides first. Can you see the slides, Dr. Saeed?
Yes, we can, Professor, but please make it in a slide mode, please.
It is in the slide mode from my end. It is okay, you can see this slide. Okay, in the presentation mode is there. Okay, good.
Yes, right.
So today I will be making a presentation on the melioidosis causing organism in the environmental samples of Bangladesh. As you know, Barbarella pseudomyeli is the organism which causes melioidosis, and this is a disease which is US select agent, and has got a lot of importance. Environmental samples are also present in there, and there is a public health importance of this disease as the mortality rate is quite high. So as you can see that is a public health and clinically important endemic disease in tropical and subtropical regions. Gram-negative saprophyte bacterium Burkholderia pseudomeli is the causative organism of this disease, melioidosis, and it is found in natural habitat such as soil and water. The disease was first identified in Myanmar in 1912, where 38 patients were identified. And the term melioidosis was accepted in 1921. And in Bangladesh, the first case of melioidosis was reported in a foreign sailor in 1964. And the second case was reported in Bangladeshi infant in 1988. These were all accidental findings. Actually, these were not looked for systematically. So you can understand maybe there might be other diseases also there. Sorry, it went out from my, okay. So till now, more than 35,000 confirmed cases are there worldwide. Southeast Asia estimated to have 44% of global disease burden. Case fatality rate is up to 40%. Highest number of 27,375 cases occurred in Thailand. Bangladesh, India, and Myanmar reported more than 89, 1,431, and 79 cases respectively. And there is a also ongoing program here in Bangladesh from ICDRB, where they're identifying cases among the diabetic patients, which I will be also telling a little bit more afterwards. A modeling study in 2016 predicted 165,000 human melioidosis cases with 89,000 deaths per year worldwide. And as you can understand, melioidosis is underreported in 45 countries where it is known to be endemic, because this disease, as I mentioned, is not looked systematically. So if you look into the map, which is up to 2011 to 2020, where you can see the distribution of the melioidosis in humans worldwide, where you can find the cases most. I can point out here, as I'm from Bangladesh, that sorry, where it has got the. Here it is a small area, not coming. Just a minute. Yes. You can see that a small area, this is Bangladesh, very small country, and this is India. So you can understand that how these are happening, how much cases has been reported so far. So this is another map I'm showing you, which is a recent map, where you can see more also what has happened, very recent one, where you can get the on a real-time basis the number of cases which are being actually reported globally. So where also you can see Bangladesh and also in different parts of the world. Even the cases are reported in Middle East also, which I will be telling a little bit on that. The clinical presentation of this disease is that there is fever, pneumonia, abdominal pain, and septic arthritis and meningitis, abscess in lung, liver, skin, prostate, kidney, lymph node, muscles, and brain. And clinical presentation in animal is also there. These are pneumonia with symptoms including severe cough, respiratory distress, and discharge from nose and eye, wasting, nervous sign, and diarrhea. So these are the animal actually gets these type of symptoms when they are infected with Burkholderia pseudomeli. And if you look into the transmission of the disease, it enters into the body through penetrating wounds or skin abrasions. Ingestion of contaminated water or food can also happen. Inhalation of contaminated aerosol can also happen, though it is not very common. Common is actually coming in contact with the infected soil and water, which is the most common. If you look into the risk factors, diabetes mellitus, renal disease, chronic lung disease, and malignancy, these are the high-risk group who can contract this disease. Farmers working mainly in the paddy fields are considered a high-risk group. High prevalence is there in the rainy season, as the organism can survive in humidity most, and I will also tell you about how long they can survive in the soil and water. Moist clay soil favor the growth of the organism also, which is understood according to the moisture. And Bangladesh is considered as the definite country for melioidosis due to the presence of Bacillus in both soil and clinical samples. High probability of presence of this organism in soil and water of Bangladesh, as the climatic condition is favorable for its growth. Rural farmers are at high risk of this disease. No previous surveillance data conducted to determine its true extent in the environment of Bangladesh. So therefore, we actually undertook this initiative to look for the systematically in the environmental samples and how it is found. So we actually set 3 objectives: detect and isolate Bacillus from soil and water samples from different districts of Bangladesh, determine geographical location, soil, water, and the other environmental related factors associated with the presence of Bacillus in Bangladesh, and also improving Bacillus pathogenomics analysis through next generation sequencing. So we had 3 objectives, but I will tell you how much we could achieve actually end of these findings after collecting samples for a year. Actually, we depended on another study which is being conducted at ICDRB for among the diabetic patient. And this study, actually, when we started this project, they have identified 90 human cases at that time from 16 districts of Bangladesh. Bangladesh has 64 districts. Out of them, 16 districts, they found these human cases. And these all were found in a hospital, big hospital in Dhaka, which is known as Burden, where they came with different complications and got admitted in the hospital. So these are all hospitalized patients where we got these 19 cases. But as of now, of 20th January, they have identified 44 cases as of now. But we didn't get the chance to go for those patients after that. But the ethical, due to some ethical reason, we could not share the patient's house address and patient's epidemiological information, because our environmental sampling was not planned at that time when they started their surveillance in the humans. So we just focused on the area where they came from. So 13 sites from 12 districts were ultimately selected for sampling. Urban sites were excluded due to the lack of suitable open spaces. For districts with multiple sites, 1 site was chosen for sampling. So it came down from 16 districts to 12 districts, and we could identify 13 sites where we thought that we will get this organism in the environmental samples. And we followed the CDC guideline for soil and water sample collection. And as you know, in Bangladesh, our lowest administrative area is village, and where we have gone to that village where the patient came from. And from that area, we have taken 100 soil samples and 5 water samples, and this was as per the guideline provided by CDC. And of those 1,300 soil samples, and ultimately there was 1,300 soil samples and 65 water samples from 13 sites. And then we transported the samples to the laboratory in Dhaka, which is known as the Bangladesh Livestock Research Institute, which they had a lot of laboratories, and they do a lot of work on environmental samples and also the animal samples. So you can see this is a Bangladesh map where we have collected samples from. These are the green ones, and these are the name of the districts where we went, and the sub-district are the name of sub-district. We went up to the village to collect the samples, the 1,300 soil samples and 65 water samples from these areas. So the soil samples and the water samples were collected as per the guideline. As you can see, 100 sample points. This is 10 to 10 grids in an area of 50 and 50 square meters. So we had to get a large area open field to get the samples of the soils. And distance between samples was 5 meters. And we collected 10 to 20 grams of soil sample at a depth of 30 centimeter. Samples collected in a sterile Ziploc plastic bag to avoid moisture loss. So this is a schematic diagram where you can see that how these are done actually and how we collected the samples. So this is the textbook where it is shown how to do it, and we did accordingly. For the water sample collection, well water, unchlorinated tank, pond, river, stagnant water, surface runoff like drain water were identified for the sample collection, and a total of 5 water samples per site were collected, and collected minimum 300 ml of water in a sterile bottle, and it was transported to the laboratory for testing. So there are some glimpses of these pictures, how the soil sample was collected and the water sample was collected from the area where we went. So some more information for you that in addition to those, we looked for the temperature and humidity also. You can see this line graph where you can see the temperature according to the sub-district where in the district where we went, what was the temperature of that area. We collected this information also separately, and also this the humidity line. So this where humidity was quite high in the environment. But when we have the season-wise looking into those, of those 13 sites, 5 site sample collected were during the rainy season, and 5 from summer, and 3 went to the spring. So this the distribution according to the season. This was not in our plan initially, but we went randomly for collecting samples, and finally we distributed this to understand that the sample of the quality of the samples. And also the soil quality is also quite important. And you can see that the sandy loam and sandy clay loam, these are the 8 sites had this sandy clay loam actually, and 5 sites had only the sandy loam. So these are the characteristics of the samples we have collected. And you can see that the average temperature was 31.9 degrees centigrade, and average humidity was 75.5, which is quite high. This is the environment initially from the climate we have taken. I would like to give one more information to you that this Berthollet can survive in soil with 20% moisture content for over a year, but only 30 days in dry soil. So if even the sample we collected gets dried, we will not be able to get it if it stays there for long, more than 30 days. And soil with water content of less than 10% can kill Berthollet within 70 days. So these are the criteria actually to get the organism in the soil sample when we collect the samples. So when we went to the laboratory, the sample preparation was made, and then media preparation was done, and accordingly these were actually put into the agar plate, sticking on the agar plate, and the colonies on the agar plate was actually studied, and from there a screening was done. What are the samples to go for PCR? We did 2 types of PCR. Initially, it was just conventional PCR, and then we went for quantitative PCR, also the RT-PCR. In the laboratory, a total of 169 isolates were screened from 1,365 collected samples based on colony morphology, and the final confirmation was performed using both conventional PCR and qPCR. Only one soil sample from a district known as Kishoreganj, which is close to Dhaka also, was tested positive for Berthollet in conventional PCR. But when we went for the qPCR, we didn't find any positive samples. So that was really surprising to us, that why we are not getting any positive samples. So to have a more that understanding of the situation, we actually did this test qPCR from BLRI, and also we went to the laboratory where the human case samples were being tested in the Bardem laboratory, and we did the testing also. Our plan was to go for, after we get PCR positive, we will go for next generation sequencing. But unfortunately, as none of the samples came out PCR positive, so we couldn't go for sequencing afterwards. So that was the part we couldn't achieve the third objective, to look into that sequencing. And as you can see that the level of identified pathogens from the sample sites were negative, we should say, not low even, suggesting that the organism may not be widespread in the surveyed areas. That was our conclusion when we came out with that. The low sensitivity of culture methods for environmental samples may have contributed to false negative results. Possible existence of viable but non-culturable bacterial cells can also happen for that. Lack of precise epidemiological data on patients' locations or workplaces limited the accuracy of site selection. The thing is that we have taken information from another study I told you, and we couldn't go to the patient's house because due to ethical reason. So if you could go there, then I think the chances of getting the organism would be more. Not only that, we don't know exactly whether the patient's address which was used was the address where they were located or they were located elsewhere. So that is also another actually might be a threat for which we have not found any positive samples. There could be other threats like the samples we collected, whether the moisture was present at the time of testing, at it was the summer season most of the time. So those might also might have caused for not getting the organism, but at least we can say that as we followed all the procedures as suggested by the CDC guidelines, might be that could be due to the actually that the organism was not widespread in the surveyed areas also, could be. One more issue also it came up, like we had the for PCR these probes and primers from CDC, and those were transported from CDC, and it seemed that there might be also some problem while it was transported. It was hand carried, so that could be another reason. But to overcome that, we did this testing in another laboratory so that we are confident that it was negative. So what is the outcome of our surveillance? The most significant outcome is the development of a surveillance protocol, which is really valid, and develop guidelines for future environmental surveillance. And we had a plan actually. For some reason we couldn't do it, but we still are actually trying to do that, to expand the surveillance in other remaining districts for a better understanding of the distribution of this pathogen. And we can focus on more cases where it has been identified, and we will try to go to the patient where they are actually located. And by this time, even in their study, they have included the ethical question also, so that there will not be any problem in future if you plan to go for near to the house of the patient to understand the situation. And the remaining districts where we have not explored can also be explored there to get the organism. So that's all about my presentation. But before I conclude, I would like to acknowledge the contribution of the Bangladesh government, the Department of Livestock Services, the Bangladesh Livestock Research Institute, ICDRB, CDC, Infinite. Actually, all these players were there in supporting this surveillance. So thank you very much. Thank you. Over to you, Dr. Said.
Thank you, Professor Rahman. That was a very insightful presentation. And this work on water and soil sampling in Bangladesh is a very good example of how environmental surveillance can be used to uncover hidden health threats like myelioidosis. Despite the fact that Professor Rahman mentioned there was a low positivity in the samples, but this is a very good exercise of building the capacity of the health systems to use and to integrate environmental surveillance in their systems. We will revisit some of the important points you mentioned during your presentation in the Q&A section here, Professor Rahman. I encourage the audience to submit their questions through the Q&A tab. We will move on to the next speaker, but before we do that, we have a question for you. We would like to get your thoughts on an important issue. Thank you, Engineer Ammar. I think you can see the question. Please, if you can take 1 to 2 minutes to respond to this question on what are your beliefs in the biggest challenges of implementing environmental surveillance in resource-limited settings. Please select one of these options. I can see the financial constraints, limited cross-sectional collaboration are leading. Now, limited cross-sectional collaboration is, as per your opinion, is the most common challenge to implement environmental surveillance in resource-limited challenges. This is great. We'll give it a few seconds. Yeah, please submit your answer if you haven't yet. All right, thank you. Thank you for your active participation. Now let's move to our next speaker, Dr. Khalid Mahmoud, who is a professor and research director of the Environmental Chemistry and Microbiology program at Qatar Environment and Energy Research Institute, known as KERI, at Hamad bin Khalifa University in Qatar. Prof. Khalid work focuses on environmental quality and nanotechnologies, including the development of renewable nanomaterials, water treatment methods, and environmental monitoring system, making him a leading voice in the field of environmental surveillance. Prof. Khalid led Qatar National Wastewater-Based Pathogen Surveillance Program, contributing to One Health and wastewater-based epidemiology initiatives. Prof. Khalid also authored around 150 high-impact publications and has strong collaboration with academic and industrial institutions globally. We will listen from Professor Khalid about the experience of Qatar, focusing on how sewage surveillance can serve as an early warning system for communicable diseases and provide valuable data for public health interventions. Professor Khalid, thank you for joining us today. The floor is yours, please.
Hello, assalamu alaikum. Good day for everyone. So please let me know if you see the screen.
Yes, Prof. We can see it and it's in this in the presentation, but please go ahead. Thank you.
Great, thank you so much. So thank you so much, Dr. Said and everybody in the Infonet for this invitation. And I'm happy to actually give this insights on what we have actually achieved for utilizing the wastewater surveillance for monitoring like infectious disease and emerging diseases in Qatar. We work on Hamad bin Khalifa University. Hamad bin Khalifa University is one of the big universities in Qatar, which actually work mainly on the environment and sustainability research. So I'm sure majority of you know and are already experts in wastewater-based epidemiology, where actually it's an important tool to analyze wastewater for access the potential risk of exposure at the community level to certain threats, whether it's going to pathogenic threats or chemical threat or toxicological threats and environmental threats as well. So wastewater-based epidemiology is not a strange tool to people. It started actually a long time ago in the 1940s when actually it was used for monitoring, or it was tested actually for polio detection in the wastewater. So ideally, what you do is you take wastewater samples from the wastewater treatment plant, the influent before treatment, and that will capture actually what is happening in it will give a good footprint on what happens at the population level, whether it's a chemical consumption or toxins or pathogens and so on. So The framework of wastewater surveillance is actually being developed recently by the WHO and CDC for trying to kind of emphasize the importance of wastewater surveillance and make a most use of it. So ideally, there are three pillars of ways to kind of fully utilize the wastewater surveillance. Public health significance, whether actually what is the current or potential threats that could happen. If we are able to identify this at early stage, we can have developed kind of an early warning system for a disease or a pandemic like COVID-19. That's actually very important to do. The other question is it technically feasible? So in terms of analytical feasibility, and this is actually one of the major challenges when we started using wastewater epidemiology or for the surveillance of COVID-19, because there was no consistency and coherency between the labs of monitoring. Every lab was doing their own kind of research tool for monitoring COVID. So there was not easy method of harmonizing this protocol, which actually got better and better later on with harmonizing, thanks to the leadership of WHO and the CDC, of harmonizing the protocol of monitoring, concentrating the samples, and actually doing the clinical testing as well in conjunction with wastewater. As well as the last one is the usefulness of action, whether the wastewater surveillance is actually important tool that can be taken for decision making, and this is actually one of the major hurdles that we have been handling and facing, whether we're able to kind of convince the health sector of being able to work with them, give them enough information or good information to support them. Again, we are not replacing the clinical system for monitoring pathogens, but at least we are actually working with them, working as a background tool to kind of do early warning of diseases where we actually with low cost, and we does not interfere directly with the patient themselves. So it was actually very important to do this kind of framework and make guidelines clearly critical for the community and for people who are actually working as a One Health approach. As I mentioned before, polio was detected in the 1940s with the wastewater surveillance, and after that, it wasn't really utilized. This tool wasn't really utilized until the emerging of the pandemic of COVID-19. So together with multiple other labs, whether in the US, Australia, or Europe, we started actually looking into bringing back the wastewater surveillance for monitoring COVID-19. And the way we have done it, taken Qatar as a model. Qatar is a very unique model where it's actually very small population, is about 2.5 million population, and the majority of them are concentrated basically in the almost 95% is populated around Doha, Greater Doha area. So we collected from 5 wastewater treatment plants that actually representing the majority of the population, and we started from the 2020. I mean, the first peak, we catch the middle of the first peak or the spike of the first peak, and we kept actually monitoring actually until today. And our efforts was actually very, very useful. We're able to kind of capture all of the spikes, and the way we have been doing this, for those who are not aware of the process, usually we collect the samples from the wastewater treatment plants, and the effluent side, we don't use the treated wastewater, so it's actually the raw sewage. We sometimes we do heat treatment just to minimize the infectious of the sample. Remember, we are not interested in looking to live virus. We are actually interested into looking into target the fragments of the virus itself that represent the COVID-19. And we take the samples to the lab and we do the pathogens concentrations, which is the very critical step. We do different types of things, whether we do the concentration using chemical precipitation, using polyethylene glycol, or recently in our lab, actually, we are using more advanced nanobeads, where we drop the volume of concentration from 200 to actually 30 mil, and we concentrate the samples, we extract the RNA, and we work with the microlethal volume, and then the rest of it is more similar to the clinical cases after we protect the RNA, and then we do the PCR and so on, very similar to the clinical sample afterwards. So here is the what we are looking for, and we capture it as a CT value, and from a CT value we'll calculate the viral load. So we'll be looking at the N1 and N2 genes. We kept doing both N1 and N2 genes, but finally we realized that N1 gene is giving us the more reproducible and high positivity of the samples. So we stuck with only N1 gene moving forward. So here is the results. It's how they look like. So ideally, we capture the image of either each wastewater treatment plant by itself. So in that case, the importance of this is we can help the clinical sectors big time by trying to kind of direct them and going into certain location versus others. So they don't have to do the clinical surveillance of the whole city, but we can tell them, okay, from the wastewater surveillance, we found, for example, in wastewater treatment plant number 1, there are actually potential of spike in the certain week, as you can see here from the red curve, while the wastewater treatment plant number 4, in the same week where we don't see a high spike. So they don't have to go to this district, and they can focus their efforts on that. So that actually was very helpful in a kind of like reducing the cost of clinical surveillance because directing the efforts into the right place. So. And when we compare actually our data with the daily positive cases that from the Ministry of Public Health in Qatar, as you can see here, of course, our granularity of the data is much less because we are collecting samples in weekly basis, and it's a composite samples that represent the whole day on that week, or we can actually pull these samples, but we report them in weekly basis, while the clinical cases maybe sometimes in days on hourly basis. However, if you can look at the trend of the curve, they actually match very well. And even if you can look at the red curve here, you can realize that in most of the cases, we are actually preceding in reporting the data maybe 1 or 2 weeks earlier than what can be seen in the hospital, and this can actually explained in multiple ways. One of them that we are actually capturing the entire population, not necessarily the one that actually go to the hospital, and even the asymptomatic patients we are actually capturing if they are silent carrier of the disease and so on. So that actually brings a very important dimension where we can actually precede the reporting by 2 weeks. Of course, we can face issues by actually false reporting the values, and maybe whether in higher or in lower. That's why we looked into finding way to normalize, and with the way of normalizing, we normalize against the RNase P, which is the human gene that actually always positive in the human samples, and this is how we were able to kind of actually normalize the value, especially when the values at very high concentration or at the peak of the infection, we get always overestimation of the numbers. That's why normalization was very important. And if you can see here, we do the model. We try to model the infected population, and we compare it with the cumulative clinical cases. And as you can see here, the model matched the trend of 30 days cumulative cases of the SARS-CoV-2, and as you can see, it's matched very well, and as compared between the model and the clinical values. We also looked in the variants of concern. So we try to match the variants of concern that's actually been detected from the clinical cases and from our cases. And we actually, at certain time, we looked at when everybody was reporting that alpha was the dominant like variants. We started in the wastewater to look at to find the beta as well. And then afterwards, beta appears in the. So we first looked at the beta from the wastewater samples before it's been actually seen in Qatar from the clinical samples. And of course, there were actually other variants of concerns that were not identified at that point, and we have actually captured it, and we're being identified later. So this is actually important things that we continue doing this, because sequencing is the ultimate tool to kind of be able to monitor and identify the variants of concern that's actually not captured from necessarily captured in the clinical cases. So we used this expertise at the time when FIFA World Cup. At the time of the FIFA World Cup, there was a challenge actually in Qatar that the agreement was to have people coming in without testing. And at that time was very challenging because the COVID was still there and people were still fearing the pandemic to come back or increase again. So, but for the fluency of the games, they decided to waive all of the pre-screening for the fans and the players and everyone. So that challenge actually was shared with us, and we started discussing with the people with the public health here in Qatar, and we decided actually to utilize the wastewater surveillance as an important tool to kind of stay on the background and screen the prevalence of the COVID-19 during the game. So we did the same thing. We looked at the 5 locations. The main location that's actually where the game are hosted, whether covering the stadiums or covering the fan zones. To do this, to estimate this one at the population level, we have to also look at the estimation of the number of population. And we were expecting actually 1.8 million fans on top of the 2.5 millions, and that's almost doubling the population. And we were trying to kind of be very close to kind of estimating the number of population. So we used the tools available to us, whether the ammonia and flow rates, and compare them with the number that we've been getting from the for FIFA World Cup organizing committee, and we realized that our ammonia measurements actually matched very closely to the number of population that's actually reported by the organizing committee. And as you can see here, very similar to what we have been doing during the pandemic, we've been also monitoring the different zones of the activities. And as you can see here, we divided this into 3 zones: the pre-World Cup time zone, World Cup time, and post World Cup. And as we expected, luckily, alhamdulillah, there wasn't a significant kind of spike or increase in the infected population, but COVID-19 was there, and actually cases were captured. And as you can see in some zones, for example, if you look at zone 3, the zone 3 was the highest on the viral load, and this zone 3 actually were the fan. This is was the main zone, was the main fan zone there. That's why there was a lot of infected population in there, but they were not threatening volume of population, and they were actually under control. In some areas, actually, there wasn't any significant threat in certain weeks. But as you can see here, after the post-World Cup, after fans are leaving and the players and so on, things went back to normal. So luckily, there wasn't any major threat, but it was a very important tool we relied on, and this reporting was very important for the organizing of the games, and it was very useful to them. And when we matched to the clinical cases, match actually perfectly, as you can see here. We did also variance identifications, and we were in control. We realized that in a majority of the cases, the major variant was the XBB1, and in some cases XBB2, which was not found in the hospital, but were able to actually find it in the wastewater. Enteroviruses and polioviruses, we found lots of enteroviruses, but we did not find the poliovirus in the wastewater as well. We have not stopped actually monitoring the COVID-19 until now. We keep monitoring the SARS-CoV-2 in our labs, and we collecting the samples on a weekly basis, and we keep monitoring this one and informing the public health authority. Currently, there is no peaks, and actually we are at the baseline, but it's good to keep going the baseline. So if any infection happens, we were able to find it. Of course, there are challenges with the wastewater epidemiology, as you can see here. As I mentioned before, it's very important to harmonize the protocol, so the different labs were able to kind of do the exact same protocol. Standardization and QA/QC is very important to have a published protocol that's endorsed by WHO and CDC. Of course, there's always a challenge of the population dynamics, because people move back and forth, they travel, they move from one location to another. This is something that actually make challenging when you model the infection of the total infection of the population. But remember, we are actually looking at the trend. So if we are consistent of our measurements on a weekly, on a daily basis, then we are minimizing the risk of this variation. And of course, the most important thing is the data sharing, and the decision makers have to actually acknowledge the importance of wastewater surveillance. And if all countries are doing this, we can able to kind of share this data together and benefit in a bigger scale. So we have expanded actually monitoring not only COVID, we have doing multiple pathogens and such as IVA, IBV, MERS, and SRV, and so on. And we keep actually improving the PCR the detection methods. Of course, real-time PCR is actually was the tool, but then for wastewater samples, we have actually shifted mainly into digital PCR because the risk is lower and you can work with a smaller number of samples and so on. And as you can see, as I mentioned, we have developed a panel for digital PCR for monitoring some of the respiratory diseases, as well as we continue doing the sequencing of these different pathogens. Currently, we have this like a panel of 66 pathogens, and we have an interest actually of increasing this one into 132 pathogens with doing the whole genomic sequencing, which is done on monthly basis in our lab. So as a concluding remarks, wastewater surveillance proven that an effective tool for monitoring emerging diseases, and can be actually expanded not only to from COVID, but also for multiple other pathogens, and can be a big support and a cheap alternative. Cannot be alternative, actually. It has to be a cheap support for the clinical surveillance, especially for knowing the certain variants that are not captured from the clinical surveillance, as well as you can also monitor the traveling pathogens. And we have a model of actually using Qatar Airways plane. We collect samples from Qatar Airways planes going east-west, and we can monitor the pathogens, and we match these pathogens with what is actually being captured in the local community. And of course, using One Health framework, it is also essential to complement the human pathogen surveillance with the zoonotic and also an antimicrobial resistant pathogens, which actually can be identified, and we are doing this in the lab. We identify different antimicrobial resistance, which can be also very good supports to the clinical epidemiology. With this, I mean, this is a few publication of what the work that we have done. If you are interested to go to these publications. And the final thing, I would like to acknowledge the collaborators and the team who actually been part and participating in this research. And we're hoping actually to continue and expand this work, and I'm very welcoming to collaboration with any members here for a future interaction and collaboration in wastewater epidemiology. And thank you so much.
This is very kind of you, Professor Khalid. Thank you very much for the interesting presentation. Qatar experience with sewage water surveillance, especially during high-profile events like the FIFA World Cup, offers invaluable lessons to how environmental monitoring can guide public health strategies in real time. I like the point where you said you have been able to detect some variants of concerns even before they appear in the human cases. That is one of the most important reasons why we should use environmental surveillance more in our systems. We will be going deeper into your presentation, Dr. Khalid, in the Q&A questions. For the audience, please keep submitting your questions in the Q&A tab. We will get to that in a minute. And now the last but not the least speaker of today is Dr. Sunday Uche. He is the science advisor for the climate change and antimicrobial resistance at the International Center for Antimicrobial Resistance Solutions, known as ICARIS. He leads antimicrobial resistance related projects in over 21 low and middle income countries, focusing on environmental dimensions of EMR and post-environment interactions in disease transmission. With his extensive field experience, he has contributed to resilience projects for the World Food Programme, WFP, and FAO, addressing global health challenges such as climate change and EMR. Dr. Sunday has over 30 peer-reviewed publications and continues to advance solutions at the intersection of climate change and public health. Today, Dr. Sunday will discuss the role of environmental surveillance in EMR with focus on how climate change exacerbates these global challenges. Dr. Sunday, thank you for joining us today. Please Go ahead, the floor is yours. Thank you. For Sandra, I can't hear you.
Can you hear me now?
Yes, I can hear you. Please go ahead. Thank you.
All right, okay. So as rightly said, I am Sando Chai from the International Center for Antimicrobial Resistance Solutions. And here I'll be taking quite just a little deviation from what has been said. Here we have listened to melioidosis, we have listened to the importance of surveillance using the case study of COVID-19 and polio as examples. Now I'll be moving into, so COVID-19, it's a very loud pandemic. Now we're going more into what we refer to as the silent pandemic. And it is important to note that every third minute, a child dies from sepsis due to antibiotic-resistant infections. And as it has been hypothesized that by 2025, which is this year, that AMR will surpass cancer as the leading cause of death in the whole world. And in 2019, it was estimated that AMR directly attributed to deaths of almost 1.27 million people and contributed to close to 5 million deaths. And not just that, if we look at the health of people, we also look at the impact that it has on livelihood, which has led to people, almost 22 million people going into poverty. And this has significantly also led to a 7.5% decline in the global livestock production. And we already know what that means when it comes to food security as well as livelihood. Now, when we talk about antimicrobial resistance, we see it as a classical or quintessential One Health issue, where for human health, it compromises the effectiveness of antibiotics, which leads to longer hospital stays, higher medical costs, and increased mortality. While for animal health, we understand that overuse and misuse of antibiotics in livestock contributes to resistance when it comes to bacteria, but this can also be spread through food to humans and also in the environment. And when we look at the environmental health aspect of it, antibiotics and resistant bacteria from human and animal waste go into the environment, furthering the spread of resistance through soil and water, as we have seen in the previous presentation. And I think for most people that are on this call, it is no longer news to know that the human, animal, and environmental health, as well as climate change, are deeply intertwined, making a One Health approach even more critical for tackling AMR globally. Just to give a little overview of the environmental dimensions of antimicrobial resistance, looking at the pathways and the impact, we understand that when it comes to the key transmission pathways, one of the most implicating aspect of that is agricultural runoffs, which is from farms and also from plants. And this comes with the seepage or the flushing of antibiotics and resistant bacteria into the environment. But also we have a very large issue of discharge from healthcare as well as pharmaceutical facilities into the environment. And we also have soil contamination through manure and biosolids, which you will see in one of the case studies that I'll be presenting. But also we have issues where, in fact, in one of the projects I might not present here, where we have seen airborne transmission through dust and aerosols that have been contaminated through with resistant bacteria. Now, when we come to human health and animal health risks, you can see that there is a direct exposure through contaminated water and food, and also, of course, water always been one of the biggest implicators. But we have seen that treatment-resistant infections in both humans and animals is increasingly becoming a big problem. And there is also compromised food security and safety, as I have mentioned previously. And also we cannot overstate the economic impact on health and livestock production. When we look at the environmental impact of this, is that it causes a disruption in natural microbial communities and biodiversity in the environment, but it also leads to accumulation of resistant genes in environmental reservoirs, and also it causes an alteration in most of the nutrient cycles as well as their functions. And we see a very big impact on water and soil quality, especially with regards to degradation. Now, just to give you some of the global perspective, here you could see that antimicrobial resistance disproportionately affects low and middle income countries, majority of which are found in Africa and also in Asia. And the GRAM project estimated that almost 5 million AMR associated deaths, and like I mentioned, 1.3 million attributable deaths in just one calendar year of 2019. And here you could see that one common factor that always remains is the disproportionate burden on low and middle income countries, especially when you look at sub-Saharan Africa as well as Southeast Asia bearing the highest burden when it comes to antimicrobial resistance. But interestingly, when we go now a step further to what we refer to as a threat multiplier, it also bears to mention here that climate change similarly disproportionately affects low and middle income countries, also in the same regions of sub-Saharan Africa and Asia. So here you can see that the first infographic here is from the IPCC report, and it shows human vulnerability to climate change. This vulnerability is accessed using 9 socioeconomic indicators from global indicator systems, and which includes, of course, as I have listed here, poverty, access to health, dependency ratio, access to basic infrastructure, gender inequity, and also looking at food security, literacy levels of adults, governance, and also health status. But here on the other map, you see here that the second infographic is from what our world in data, and it shows that African countries have the least carbon, not just African countries, but you can see also some part of the Asian countries have the least emission of carbon, whereas they suffer the most impact of climate change. And it takes me to what I call here the unholy alliance, where climate change and antimicrobial resistance have caused or have formed what we call the unholy alliance. Now, climate change has multiplied the threat of antimicrobial resistance in different ways. Either talking about hydroclimatic conditions or we talk about temperature. For the sake of this presentation, as I have not so much time to present, I will focus solely on the impact of temperature. And you see here that temperature is critical to bacterial processes and infections. As temperature in itself increases with climate change, bacterial infection rates may increase, and also disease can spread to higher altitudes and latitudes where they were not previously found. And if we look at some of the examples here on the table, you will see that with rising temperature in water systems, this contributes to better survival of bacteria such as Campylobacter, Salmonella, Vibrio that cause waterborne and also foodborne diseases. And we have also seen that Candida auris has gained thermotolerance and salinity tolerance also in wetlands, which is something that was not previously seen before the alteration in our climate. And also you could see here that E. coli and some of the escape pathogens now grow optimally even between temperatures of about 32 to 36 degrees. And we see here that when we look at the macro movement of this resistant bacteria, you see that infection rates may increase and disease can spread to even higher altitudes and latitudes, like I mentioned. But also when you look at the micro movement, we have an increase in horizontal gene transfer, which is largely facilitated due to higher temperatures. Now, having understood all of this, we'll ask the question, then why are there not a lot of interventions to mitigate this? And this is because even though thousands of AMR intervention projects have been executed, the successful ones are only a fraction of this. And this is simply because there is a number of reasons that affect this. one of which is the political will or policy commitment. And the reason why we have very poor political will or policy commitment is, one, simply because there is insufficient surveillance data to demonstrate the extent of the problem. And you will see in the subsequent presentations where even within ICAS, we have paucity of interventions in the environmental sector simply because there is no sufficient evidence from surveillance data to demonstrate the extent of the problem. Secondly, because there is no sufficient data, even understanding the consequences of this AMR problem becomes a challenge. And because of that, you are not able to give a convincing business case for why there should be political or policy commitment to this. Secondly, when we come to local ownership, looking at engagement or behavior change from different stakeholders, you also realize that there is suboptimal knowledge, attitude, and practices on AMR and its consequences. And why do we have this? It still comes back again to one important issue, which is because there is insufficient surveillance data to demonstrate this particular issue in this area. So because of that, you are not able to inform or convince or change knowledge, attitudes, and practices. And because there is this absence of this data, there's also lack of acknowledgement of the importance of understanding the need for implementation research. And then when we look at human capacity and also infrastructure, in the beginning, there was a question around what is the biggest barrier to why we don't have surveillance. And in most instances, we have seen that human infrastructure and also operational resources are missing. Now, for any intervention that we would do from ICAS or with a partnership with any country we work with, we realize that scalable, successful interventions are usually based on research that has both intervention and implementation component to it. But how can we achieve this? It means that first, there must be a need by the political class. And the way to get that is by us getting data that will be able to convince them. And how do we get ownership throughout the whole stakeholder chain? There must be data to convince every stakeholder about the importance of this issue. And another important thing that we need to realize is that it's easy to extrapolate using other evidences from other countries, but we have come to realize that we must develop context-specific interventions for specific local problems. And how can we do this? We still go back to surveillance. We rely on evidence-based knowledge to be able to do this. And by so doing, we ensure that for every sustainable solution, there must be a component of capacity building, but also to be able to change behavior. And all of this will still also have to come back to the cost effectiveness of any intervention that we're doing. And that is why at ICAS, we are working to reduce drug-resistant infections in low and middle-income countries, where we see that there is a need for solutions that are based on evidence, cost-effective, context-specific, sustainable, that covers the One Health spectrum, but also strive to close the gap between policy and practice. And that is why ICA's mission is actually to partner with low and middle income governments and research institutions to co-develop and test tailored solutions with potential for scale-up. This is just to give you an overview of our presence globally. And you can see here that when it comes to the Eastern Mediterranean region, that we have very few projects that are currently ongoing there, and we are hoping to expand. But what I want to point specifically here is that here you see that wherever you see the icon of a tree or a plant, it depicts the project and environment. And in the whole of this map, you see that so far, or as I said before this year, we had one project that is currently ongoing in the environmental sector. And the simple reason why this has been the case is because before now, there has not been sufficient convincing surveillance data to demonstrate where the AMR problem is within countries. So this actually buttresses the need to also invest in surveillance as well. This is just to give you an idea of some of the projects that we have currently ongoing. So we mentioned about the need for environmental surveillance, especially because of the impact of livestock production into the spread of antimicrobial resistance. And here we have a project where we are trying to understand the role that poultry manure plays in the dissemination and contamination of the environment with antimicrobial residues as well as antimicrobial resistant pathogens and genes across the food chain. And this project is targeted to test and optimize a simple, cost-effective poultry manure processing process to reduce the antimicrobial spread through safer and more cost-effective treatment of manure. And here, basically what we intend to do, or what we are doing, is to introduce manure processing technology to treat manure in Tanzania. And this is solely because we came to realize that poultry manure can be a reservoir of zoonotic pathogens such as E. coli, Salmonella, and also Listeria and Campylobacter. And environmental contamination in horticultural farms with poultry manure actually interferes with soil microbial population, but also it adds to transferring antimicrobial resistant genes to this soil microflora. And just to move a bit again to Cameroon, where they have issues with untreated wastewater that goes into the public water system. And this issue is particularly critical in the Yaoundé area, where urban agriculture plays a vital role in food security and employment. And this is also complicated with wastewater that harbors resistant bacteria and resistant genes. And despite the importance of this, there is also still the issue of lack of sufficient evidence. So we still come back to the issue of surveillance again. And what we intend to do in this case is to develop a project to interrupt the AMR transmission cycle to safeguard public health and also promote sustainable agricultural practices through targeted interventions and collaboration. And the whole idea is to have a cost-effective strategy for AMR reduction in this. And in the course of this project, there will be collection of baseline data to help in the refinement of some of the protocols that will be used for this. And now if I move to the Eastern Mediterranean region, also using the WHO classification, we go to Tunisia, where wastewater treatment plants are a major source of environmental contamination. And based on the evidence that has been shown based on surveillance, 69.4% of water samples contain E. coli and Klebsiella. And the incomplete metabolism of antibiotics in human and animal actually also contributes to the residues which are found there. So that is why now the current treatment processes that are being used are not sustainable and are not also sufficient. And that is why in this part of the project, we are trying to adopt nature-based solutions such as constructed wetlands to be able to address this. And also here we are having a project where we are trying to look at the incorporating climate change strategies into AMR intervention and implementation research projects. And the whole idea of this is to test context-specific interventions around how we can bring about a win-win when it comes to the mitigation of climate change and AMR at the same time. And how can we be able to do this? We still go back to rely on evidence that have been generated in different contexts. Now, when we talk about how do we address some of this or the mitigation strategies, it comes back to improve waste management systems in healthcare and agriculture, but most importantly also to reduce antimicrobial use in livestock production, to see how we can advance on treatment technologies that take into cognizance antimicrobial resistance and also resistant bacteria, but also have improved biosecurity measures in farms, which also reduce the need for antibiotics and also begin to think of alternatives in health management. Now, when we come back to policy and monitoring, it comes back to the need for environmental surveillance and monitoring programs, and also regulatory frameworks that incorporate antimicrobial use and disposal, but also we need to think about research and development around sustainable alternatives, and of course sectoral collaboration, which we will all agree that it's one strategy that is mostly required. And I always appreciate this new definition that was recently published by the One Health high-level expert panel and endorsed by the tripartite and UNEP, which defines One Health as an integrated, unifying approach that aims to sustainably balance and optimize the health of people, animals, and ecosystems, but it recognizes the health of humans, domestic, wild animals, plants, and the wider environment as being closely interlinked. And I'm sure in the course of all of these presentations that you've had today, you can see that this approach mobilizes multiple sectors, because what goes on in the environment comes back to humans, comes back to animals. And I always say that at the center of One Health is that everybody lives within an environment. So if the environment is altered, then all other health sectors are altered. And in the course of us trying to build a community around solutions for integrating AMR into global challenges, we have started establishing what we call community of action on AMR and climate change interventions. And you feel free to scan the QR code if you want to be a part of this. And I want to use this opportunity to appreciate all our partners, who are quite too numerous to mention, and there are so many that are not currently captured in this slide. And with this, I say thank you so much for listening. Over.
Thank you. Thank you very much, Dr. Pache, for the thought-provoking presentation. You clearly demonstrate the importance of multisectoral collaboration in One Health approach. We keep saying that multisectoral collaboration under One Health, but you gave very practical examples of that. I'm conscious of time. I would like to pose some questions to our distinguished speakers. While I'm going for the questions, I would like you to share your thoughts again. I would kindly ask my colleague, Engineer Ammar, to post the question. Thank you, Ammar. And I would like you to respond to this question. We would like to hear from you. And in the meanwhile, I will try to address some questions to our speakers. And for the audience, please keep posting your questions. And don't worry if the time didn't allow us to finish the questions. We will make sure to communicate with the panelists and send you the answer after the webinar. I would like to thank all the speakers for the insightful presentations. And I would like to pose the first question to Professor Mahmoud Rahman. And I can see from the questions from the audience on the chat that some colleagues already start thinking about how to implement environmental surveillance in their countries. And we would like to hear from you, what are the primary challenges that you faced while implementing environmental surveillance for Barbados, Sudan, and myelodisis in Bangladesh? Please, Professor Rahman. Thank you.
Thank you. Actually, the challenges we faced, some methodological challenges rather what we faced, like when we selected areas actually for these environmental samples, the guideline we had to follow, it was very difficult to get samples from the urban locations, because we have to go for an open area and to have a 50 by 50 square meter from where we had to collect samples. So that was not available in the urban areas. So we faced initial problem there, and we had to drop the urban sites also, not getting the samples from the site we wanted. In that case, we have to go to the outskirts of the urban areas. So that is the methodological challenges we faced. The other challenges we faced was in the laboratory testing sites, when we are doing, as we were not getting positive samples, and also the transportation of the probes and primers from CDC. These were the challenges we faced, other than the other financial issues, which we don't want to bring it here. But as a whole, for environmental surveillance in this country, it is a challenge, because there are competing priorities with other diseases. So bringing it to the policymakers to have this happen is not easy. So we depend on the development partners mostly. But it is a good opportunity for environmental samples, where we did it for AMR also in the past, which is also not very much dependent on the government sector funding. So it was really a challenge there in doing that, but it has got a lot of public health implications when we have done this together, environmental samples from the human, animal, and the environment together. Over.
Thank you, Professor. I think these are very excellent points, and I think colleagues in the audience might make use of avoiding these challenges or develop mitigation strategies before pursuing environmental surveillance projects in their countries. Along the same lines, Professor Khalid, if I may ask you about your experience in Qatar, what were the major challenges of implementing environmental surveillance? You presented a very comprehensive and very advanced system, and we would like to hear what were the challenges and how to overcome them. Because we realized from your presentation that it has a very important role in addressing the emerging and re-emerging infections under the One Health approach. Thank you, Professor Khalid, please.
Thank you, Dr. Said. I think the major challenge, I mean, there were actually initial technical challenges, which is, as I mentioned in my presentation, of the harmonization of the protocols between labs, so the data will be consistent if it can be reported and shared. We mostly overcome this challenge now with the help of actually now CDC is trying to kind of publish the like harmonized protocol, and WHO and also the same thing. The current challenge is now the acceptance of authorities to kind of continue doing this surveillance, because once the pandemic is over, the decision makers realize, well, I mean, this is somewhere where I need to invest more money, or we'll just need to stop because there is no importance for it to continue, which is something that we're trying to keep convincing the decision makers that we need to continue this and you keep funding this, because without funding, research labs we're going to lose the interest as well if no publication coming out of this. The third challenge also is the data sharing. Some like, I mean, some labs or some countries, like, they feel that this data is like really confidential, it cannot be shared, which is not actually the mandate of this surveillance. We need to, especially if we want to talk about traveling pathogens, if we want to actually see monitoring variants that's actually going from like the eastern side to go into the western side, and whether these variants are actually mutated and they're changing their futures if they go from one environment to another. Without data sharing, we'll not be able to kind of put the dots together. So hopefully, with more awareness and more workshops like the one that we are doing now, I hope that there are going to be more decision makers listening, and we'll keep this wastewater surveillance alive, and it will be very beneficial to continue.
Thank you, Professor Khalid. And it's very interesting to notice the themes, the similar themes in challenges between Bangladesh and Qatar, despite the fact that these are two different contexts. The two set of challenges share the political will and the policymaker. That's why I would like to ask Dr. Sunday on, because you mentioned that in your presentation as well, how can we use the environmental change strategies and policy implementation frameworks to be effectively integrated to bridge the gap between the antimicrobial resistance and climate change policies and the actual practice? Because sometimes we will be convinced that there is something to be done, but in the actual life it's not happening. So how do you see the interaction between the two? Thank you, Dr. Sunday.
Thank you so much. So pardon what I'm going to say now. Usually I always say when it comes to politicians, it's usually how much and how many votes. So if your case is not able to convince the political class that this is going to bring, there is going to be return on investment. And return on investment here might not necessarily be profit in the form of cash, but if, for example, they are able to invest in surveillance, what can they do to be able to save in the future? So for example, like Dr. Khalid presented in his own case, where they are able to dictate the presence of pathogens even before they get to humans. So here it's more or less around the issue of economic impact evaluation of health, where, for example, if you're able to quantify how much the government is able to save in treatment as against surveillance, then that actually it's always a very valuable tool to convince policymakers. But just to give a classical example of how we approach our projects in ICAS, we operate what we call the top-down and bottom-up approach. So before a country approaches us to say they want to do a certain intervention, we ensure that there is a political commitment by the responsible ministry and government, and we must make sure that interventions are cost effective. And the reason why I keep emphasizing on cost is because you all agree with me, Professor Raman and Dr. Mahmoud here, that cost is always the determinant of how much government is willing to invest. So if, for example, you come up with so usually in ICAS, we rely on the fact that surveillance has been done, the problem has been identified, and then we come around testing solutions that are able to address these problems that have been identified. But usually we are not able to do that in a number of contexts simply because there is absence of that data. And it comes back to when we come back to government and say, okay, this is the cost of surveillance. How much is the government willing to pay for it? Just to give an example, we have a country where there is a big gap between the animal health and the human health when it comes to budgetary allocations. And this usually, and it's even worse more for the environment, because the environment in most sectors are not usually into surveillance for pathogens. They are mostly into metals and some of this, but not for pathogens. So in this case, what happens is whenever there is need for surveillance, the people in the medical field are able to go to the field and get samples, while the people in the animal health sectors are not able to do that because they don't have the budget for it. The people in the environment are not able to do that. So what we were able to do is to discuss a model where whenever there is going to be a need for sampling by the human health in a community, that the people from the Ministry of Environment, people from Ministry of Agri are able to join them in that mission. And while they are collecting one sample for environment, they are also collecting from, so if they go to a household, they collect samples from the people, they collect samples from the animals, they collect samples from the environment. And by so doing, you are able to save costs. So this cost brings about cost effectiveness. So I think to be able to convince policy and to be able to bring about the intersection or the integration between policy and practice is to look at political will, which always comes back to cost effectiveness. Let me stop here for the sake of time.
Thank you. Thank you very much, Dr. Sunday, for this insightful reflections. Conscious of the time, I promise again my audience that we will answer your questions and share it back with you. And I'm glad that our today's webinar has demonstrated that environmental surveillance is not just a tool, it's a cornerstone for building resilient health systems that can adapt to emerging threats. Let's take this knowledge and actionable insights shared today to strengthen our collective efforts in advancing environmental surveillance. Whether through research, policy, or practice, we can all contribute to building resilient health systems and safer and healthier futures. On behalf of Infinite, I would like to extend my heartfelt thanks to our panelists, Professor Mahmoud Rahman from Bangladesh, Professor Khalid Mahmoud, and Dr. Sunday Chai for sharing their expertise and experience. Your contribution today have been invaluable. I would like to thank the active audience for their active participation, thoughtful questions, and commitment to advancing One Health principles. It's your engagement that makes sessions like this impactful. We will be sharing recording. I noticed some colleagues asking in the chat that whether they will be having the slides. We will be posting this webinar recording in our Infinite YouTube channel in the coming days. Please stay tuned and check that out. Thank you once again for joining us. Let's continue working together to advance environmental surveillance and build resilient health systems for a safer, healthier future. Have a wonderful day, afternoon, or evening, wherever you are. Goodbye.
Bye.
Thank you. Bye. Bye, everybody.
Bye.